name is Jason Hauser, and I'm a senior underwriting advisor here at Optimum Re. And this morning, I wanted to spend a few minutes discussing GLP-1s. Very interested with the history of the GLPs, their use, the expansion. And as you can see from the title of our talk this morning, we're going to talk about the expanding promise and the persistent challenges that we're seeing currently in the marketplace, and kind of look forward a little bit. If anyone is interested, I would encourage you to go out to our Optimum Academy. In mid-2023, Dr. Joannides did an excellent webinar on Ozempic and weight loss drugs. So if you're interested in learning about them from a medical perspective and taking a deeper dive, I would encourage all of you to check out that webinar. So this morning, let's talk about GLPs and their rapid expansion and growth. Initially, when they hit the market, we looked at them from somewhat of a niche perspective, in the sense that we were really only focused on two specific situations or impairments that we would be looking to treat, and that was type 2 diabetes and obesity. That is changing very rapidly. As of 2025, the adoption rate for writing these prescriptions and for their use is being reviewed, and it's surging across the United States. It's expanding globally, and it's driven by a number of different factors. It's driven by the urgency of need in the public health sector. It's driven by a growing clinical evidence that there's positive value for prescribing these medications. And certainly, I think from a market perspective, we see unprecedented demand in the desire for these prescriptions to be written. So with that, let's look at a little bit of a historical backdrop. We have CDC data that shows nearly 1 billion people globally that are projected to be living with obesity. So again, knowing that obesity and diabetes were kind of the catalyst for these medications, looking at obesity statistics, 850 million or 1 billion people with obesity, and 850 million diagnosed with diabetes by the year 2050. In the United States alone, 15% of adults have diabetes, with millions more of them not knowing, going undiagnosed. So again, going back to GLP-1s and looking at that backdrop, they were developed and taken to the market around 2005, specifically for type 2 diabetes and obesity. And again, they are increasingly being recognized for their therapeutic potential. And FDA approvals have grown. They've increased, and now we're looking at cardiovascular disease, sleep apnea, diabetic nephropathy, and more. So you'll see that trials are actually underway for future indications, which include congestive heart failure, osteoarthritis, liver disease, and Alzheimer's. So what I've done here was, as I started compiling information, I had listed out all the different medications and their current application, whether they were subcutaneous or whether they were oral medication. And what you see from the chart is that we have a current application and approval by the FDA for multiple uses. And up in the upper right-hand corner of the chart, I show what's currently approved and for what impairments we're actually using these medications for. I show what we have pending currently for 2025 by the FDA, and I show what's in the pipeline and being considered for those specific impairments. I felt like it was easier to show a graph and for reference than to list out 16 different medications. But the use is expanding rapidly. And I think what's really unique and what's interesting about this is, even beyond the impairments I've listed here, a couple of other things that we've discussed internally and I've read about and researched is that we're also seeing potential value in maybe alcohol addiction and potentially even things like gambling addiction. So the protective value of the medications and their use is being studied for a broad swath of application. So I think it's interesting, and I highlighted this, but We are going to see at some point an oral medication come to market for some of these conditions. So it won't just be for anybody that's leery of using the needles and the applicator, that there are going to be alternative options that come to market here soon. So what does all of that mean? Well, I think they're all good. From an underwriting perspective, we certainly see value when people are utilizing GLP-1s, especially when they're being treated for those particular conditions that we talk about. But it also poses some challenges for us in the marketplace in a general sense. And so I've wanted to highlight a few of those this morning and discuss them. So critical concerns. Demand is outpacing systems. Between 2017 and 2021, the demand for the prescription of a GLP-1 has risen 40 times. So that's patients that were taking Ozempic and Mounjaro specifically. So as a result of that, we've seen stress in supply chains, we've seen stress in provider systems and insurance programs, and I highlighted specifically Medicare Part D. So Medicare Part D is interesting in that in August 2024, they actually have given access to over 3 million individuals participating in those plans for GLP-1 use covering diabetes and cardiovascular disease. It's not yet been approved for weight loss, as other providers might allow for that, but those two things specifically. And what's happened is it's putting stress on the Medicare plan itself. So spending or approved spending has risen in Medicare Part D from $57 million to $5.7 billion just on by the end of 2022, just on allowing GLP-1 usage. And we're talking about now with the addition potentially as they look at adding obesity to the program. So not just for treating diabetes, but also cardiac disease and obesity. It's going to drive Medicare's projected costs to over $8 billion within the next decade. So as a result, when GLPs are being approved for use, for a broader use and expansion for insurance plans or by PBMs, we need to see broader infrastructure and policy adjustment to support the long-term access. Otherwise, some of these providers are going to see some significant challenges moving forward. And with that, we also have challenges with disparity in terms of access and off-label use. And when I say off-label, what I specifically mean is weight loss, because again, the focus initially was type 2 and then of course obesity. But when we focus on the weight loss portion alone, what's happening is diabetic patients are experiencing shortages and their inability to get the medications. And from an underwriting perspective, I think we tend to see a couple of different scenarios that come into play. One would be that a doctor will work with the patient and they go through this process where, the strategies are employed, whether it be lifestyle modification, diet, exercise, and the prescription is written as kind of a last resort or a last line of defense in step of treatment. Whereas in the past few years, one of the things that we've seen on a rapid rise is that patients are going into their doctors and they're almost demanding this drug be prescribed to them as a first resort. They're not looking at the other options first. They specifically want Ozempic or Wegovy. You got to give it to me for weight loss because I know it works and it's almost like a magic bullet or a genie in the bottle. So it's creating some significant challenges. There are insurance coverage gaps between the public and the private systems and between different drug indications. And so again, that's leaving the diabetic patients without access to the medications that they need. The good news is, though, that the maker of Ozempic and Wegovy, which is Novo Nordisk, has reported as of February 2025 that the FDA has updated that list and the dosages of the injectables are being resolved or have been resolved. So technically there is no shortage on Ozempic and Wegovy at this point in time. The other challenge that comes with any medication that comes to market and we see a rapid increase of would be unclear long-term safety. So we see right now the use starting to outpace the safety research, and we understand that every single medication undergoes rigorous testing and trials within the FDA or any other manufacturer. But we've had some examples where even well-tested medications, going back to Victoza in 2013, the FDA had to put a warning out to market about potential pancreatitis as a result of use. And then we had semaglutide users reporting suicidal ideation, and they were having trouble with hair loss. And those came after the medications were approved and were on market. So the FDA has actually cleared up those concerns over those specific, more recent issues as of early 2024. But it continues to highlight the ongoing need for a robust post-market surveillance, transparency in the market by the manufacturers, and ongoing cataloging of those particular issues, so that when new medications are being developed, they can take those factors into account. And obviously, again, for the consumer, the transparency and the side effects are important, specifically if they're on other medications that might counteract with this medication being prescribed. The other thing that happens as a result of shortages, and some of it's good and some of it's bad, is alternative sourcing and the rise of generics. So what we see are cost barriers and access that push patients toward non-traditional or gray market sources. Dr. Joannides also has spoken about this, and the thing to remember about the gray market is that you have a few issues that come to light. Number one would be lack of regulation. If products are sold in the gray market, they're not necessarily subject to the same standards, the quality standards and safety standards that the FDA would utilize for approval of a drug. Sometimes those dosages may be different as well. They may not receive, an individual that goes out to gray market for a medication may not receive the correct dosing. They may not get information or guidance that they need about how to utilize the medication, and that could cause health complications for that individual. And then thirdly, there's a lack of transparency at times in that market. The origins or the composition of those specific medications might be somewhat unknown, and it could be difficult to determine their safety and whether or not they're effective. But as a result of kind of all of these factors, what's happening is we're starting to see generic, or what we call biosimilar, alternatives coming to market. A biosimilar, by definition, is a similar version of that original that's manufactured using a slightly different process. When we see what we consider or call generics or biosimilars, most of the time they're also more affordable than the original medication. I think one thing to pay attention to for us, both in the underwriting space and in the market, is that the original patent for semaglutide actually is set to expire in 2026. So what I think that's going to mean for us and for the consumers in the marketplace is we're going to see an explosive growth in that space when we see generic medications coming out, biosimilars coming out. And I hope that the result of that is there's some alleviation of financial strain in the market for consumers, and there certainly is improved equity, and hopefully within policy and pricing framework for those medications as well. Hopefully all of those things line up. And then lastly, this morning, I think in reflection, I think these GLP-1 RAs are certainly going to continue to play a central role in the future of chronic disease management, particularly when it comes to obesity, diabetes, heart disease, because we continue to see their application increasing, and we know that those drugs are being studied for additional use. I think the therapeutic reach is expanding quickly. I think the promise is substantial. And I think the trajectory does reveal some stress points in the system. I think, again, going back and looking at supply, affordability, coverage, and safety. I think those things need to be addressed on a proactive basis continuously. And I think if those things are managed well, I think this class of medications reshapes outcomes for millions of people that need them. And I think if we don't do that, I think we're going to continue to see the access gaps and the inequities deepen in the marketplace. And finally, I think Optimum is continuing to stay informed as far as the development and new medications that are being brought to market, expansion, changes to existing medications. And I think that our in-house medical staff, as well as our R&D teams, are consistently doing current research on the latest trends, the impacts to both clinical and insurance medicine in that particular space. And I think that for anyone that gets the opportunity to watch or rewatch this session, if you have any specific questions on anything that we've touched on just at a very high level today, please feel free to reach out. As Dr. J always says, if you reach out to us via email or if you want to give us a call, I think we're more than happy to assist, and we'll do whatever we can to answer your questions and give you access to all of the additional continuing education that you're looking for your teams and for your organization. So with that, I'm completed with the webinar for today. I just want to thank you for your time.